All right, good morning, everyone. We're going to get started. Thank you all for joining us this morning. My name is Dana Slowinski, and I'm co-owner of Family Recovery Centers. And we're very excited for you to join us for part 2, Dissociation part 2 with Paula Merucci. And I will get to introducing her in a second. I just want to take a quick minute to give an overview of Family Recovery Centers for those of you who are not familiar with us. We are an intensive outpatient program for adolescents and their parents. It's an evening program, and we have 3 locations. We're in Lake Bluff, Hoffman Estates, and St. Charles, and we have a 4th location coming this fall, so details to follow on that. We work with a wide range of adolescents with maladaptive behaviors, from substance use, self-injury, mood disorders, and 2 program components that I like to highlight are the family involvement. So parents are actually on site with their kids 2 of the 4 evenings that the kids are with us. So they are not only learning the skills right along with their child, but they're also doing their own work, and they're working on their role and dynamic within the family system so that we can really wrap around that whole family system. And then we also have a 24/7 on call. So our staff is available to both the parents and the patients 24/7 to help with the in vivo skills coaching, so that they're not just coming to us during the 12 hours a week, but we can also help them really in their own environments, in their own lives. So that's a very quick overview of us. If you do have questions or want to talk further about Family Recovery Centers, please feel free to reach out to myself or Ryan Bright, and we'd be happy to talk about that. And with that, so Paula Merucci is an absolute wonderful trainer and presenter. And so we are very excited to have her back for part 2. She is an EMDR approved consultant and EMDR certified therapist. She's a national trainer for EMDR Consulting, LLC. She's a speaker and facilitator for advanced training, Introduction to Structural Dissociation, Ego State Therapy, and EMDR Therapy. Workshop provider on trauma and dissociation. And as you can see, she wears many, many hats. She has also graciously offered to do a 3rd webinar for us in April. So mark your calendars for April 20th. We're going to be doing a 2-hour webinar on the polyvagal theory. So, and Paula will speak to that during this webinar. So you'll have a little information throughout today. A couple of logistical things. The PowerPoint will be sent to you in your email, so you will have access to the slides. And if you have questions, we already have one. Yes, you will get copies of the handouts and the PowerPoint. And if you do have questions throughout the webinar, please feel free to either put them in the Q&A or the chat, and then Paula will save time at the end to go through the questions that haven't been answered throughout the webinar. So with that, I will turn it over to Paula.
Yay. Okay.
Oh, and I'm sorry, Paula, really quickly, there is one question already. So if we miss part 1, is that being offered again soon? So that part 1 is actually on our website. So familyrecoverycenters.com. You can access it. Just go into the webinar portion on our website and you can access it there.
Yep, they're all recorded. This one's going to be recorded as well, so you can go back and watch them. So thank you. Thank you for that wonderful introduction. I always like to start out when I'm working with this particular agency in that I have a personal relationship with them. Back in the day when I was raising children a long, long time ago, they were life changing for me in not only educating myself and my family on how to deal with some really difficult times and situations. But I'm just really excited to be able to report that my daughter, who was the one that we were focusing on at that time, is doing great. And so I'm so grateful to the work that they do. And so I just always put that out there. And so Ryan and I go way back. So with that being said, the passion that I am experiencing around doing this work does come from my own past, which we'll get to in a minute. So we did dissociation part 1, and there was some great feedback in that everybody wanted to kind of see, well, okay, what were those tools that you referred to and what would we do next? And so hence here we are with dissociation part 2. And we're really going to hone into the modifications that we can use for safe and successful processing. So just to introduce myself real quick, because there are going to be some people out there that don't know who I am. I am Paula Merucci. I come from the Chicagoland area. I live in what I call Heavenston, which is Evanston. And I am absolutely in love with and very passionate about EMDR, but also want to honor the fact that dissociation is something that we're seeing a lot of. And so it's really important, if we're going to be EMDR therapists, that we're in fact just trauma-informed therapists. And you, in order to be trauma-informed, we need to understand dissociation. And also, before I continue, you are going to get a copy of the slides, and you are going to get a copy of the recording if you'd like it. So I'd really, there's going to be a lot of information in this presentation, not necessarily for you to learn it all today, but I'd like for you to just really be able to sit back, drink your coffee, if it's that time of day for you, and just kind of just process the information that you're going to hear, and just know that you will have access to it going forward. Okay, so I always like to tell my own story, because it's not like I woke up one day and said, oh, I want to be a trauma therapist today. I actually had a career, started out as an engineer. I was in business. I worked at the Board of Trade. I had a family. And then as I saw my own trauma creep into my parenting and my own children, that's when I decided to go back to school and become a therapist. It's really fascinating how being in therapy for as long as I was, how my trauma really wasn't dealt with. And my therapist was wonderful, and I made great life choices based on the therapy that I got, but it was talk therapy. And to be honest, my trauma was stored somewhere else. It was in my body. It was in my right brain. It was about experiences. And unless we went digging and did that deep dive, it wasn't going to come up, and it didn't. And so then I heard about EMDR, and being at that point a therapist working with addiction, I'm like, there's got to be other tools out there. This is insane. Like, I don't know what these people are going to do. There is so much trauma. Fast forward, EMDR, got my own EMDR, thought, wow, and then decided that I wanted to teach it. Not only do I want to teach it, but I want to teach it to as many people as possible. Story doesn't end there, hence a pandemic. And now we're seeing so much dissociation, and we were probably seeing it before, but it's just so much more apparent now. We need to really understand how to work with dissociation first. And it doesn't matter what orientation you use to do your trauma work. If we're going to be trauma informed, we need to understand dissociation. And if you're going to be a therapist in this day and age, I think you need to be trauma informed. So if this is your first introduction to maybe what trauma informed looks like, that's okay. My EMDR trainings, I feel like a lot of my participants are just for the first time. Like, I'll say, how many of you understand dissociation and work with it? And like 20% of my participants will say, I don't know. And then I'll say, who's Pierre Genet? And another 20% may say, I do know. And so, like I said, becoming trauma informed is very important. It's a journey, and there's a lot of us that are on this journey. And so, you know, no one's alone. No one should be alone in this work. You know, Peter Levine, who we've all heard of, says trauma is the most avoided, ignored, denied, misunderstood, and untreated cause of human suffering. And so here we are, and I really appreciate all of you taking your time to be here. Some of the things that I do, once again, I just have to blow through these. I am a trainer in person, trainings in the area. Gurney's my favorite place to train. I also try to make it out to Naperville. So this is just an example of some of the in-person trainings that I do. And these are going to be EMDR basic trainings. Also, I do virtual trainings. Very grateful for the opportunities that came out during the pandemic. Virtual trainings were never, ever going to be a thing, and neither was EMDR therapy online. And not only is it very successful, but some of our highly traumatized clients actually do better virtually because they feel so secure in their space. And we're going to talk about that as we talk about dissociation today. I'm honored that I've been invited to work with Farnsworth Lobenstein. He is brilliant, and he works with structural dissociation and ego state therapy. I have a lot to learn. But not only do I get to coaches trainings or facilitators trainings, but I'm also a guest presenter, a permanent guest presenter is what I've been told recently. So that's been very exciting. And then just want to put out there that we are not alone. Like our EMDR community, we used to have a regional EMDR meeting led by Robert Merucci, our regional director. And so when we went online, it went global. And so now our next meeting is April 10th from 12 to 3. I'm actually going to be doing this presentation, but it's going to have how to utilize EMDR with the tools that I'm going to be teaching you. But it's not uncommon for our EMDR therapists to also need to learn more about dissociation. Okay. So my favorite book, and I've had to read it many times because I literally dissociate while I'm reading it, is Judith Herman's Trauma and Recovery. It is a beautiful book, and it is a harsh read, but it is wonderful. And if you really want a place to start, Judith says the core experiences of trauma are disempowerment and disconnection from others, and recovery, therefore, is based on empowerment of the survivor and the creation of new connections. And that very much reminds me of recovery work that I do with addiction, because addiction is in isolation and recovery is in community. So not a whole lot of difference there. The trainings that I do, it's very important. I'm dyslexic. And so I put that out there because I switch a lot of things around. There was a participant at the last training that reached out to Ryan and said, hey, there was some mix-ups on some slides, and I really appreciated that, because I went back and lo and behold, absolutely correct. I had switched around some language. And so if you see something, by all means, I do not claim to be perfect. And I would just really like to make sure that my presentations are on point. So if you see something, by all means, don't feel bad letting me know. Knowledge is power is one of our main mantras, because when you hear it, you're learning it, and it is empowering, not only for us, but for our clients. We want to engage also in the research, and the learning pyramid tells us about how when we demonstrate it, we discuss it, and we practice it, you can get that learning retention up to 75%. In all 3 of the trainings that I'm involved in, we do not only demonstrations, but we have long practicums where you're the therapist and you are the client. And then also we do a lot of videos to show how it works. And then of course the hear it, see it, and then you go out and do it. And we just want to be with you every step along the way so that you're not doing it alone, because no one should ever do any trauma work alone anyway. So the objectives for this particular dissociation part 2, I'm going to continue to talk about like the window of tolerance and the DES, the dissociative experiences scale. There's going to be a couple slides that you're going to say, hey, we saw that one already, and that's okay, because that's part of the learning. And then we're going to go into the tools that I left with in part 1, and we're going to walk through each tool and how to use them.
Hey, Paula.
So, yes.
I'm sorry to interrupt you. I just wanted to let you know that it looks like someone had noticed that there is that black box at the bottom of the slides. And I think if you can, I think you can still see all of your slides. So I think it's okay if we can't do anything about it. I don't think it's taking away from any part of the slide.
Yeah, you know what? And then I just, I know what it is. I just have to figure out how to get rid of it. Screen. And no, that's not going to work.
You know what? I think it's okay, because I don't think it's covering any text. So I think we can.
Yeah. No,
it is taking.
I can move it around, but I just don't know where to put it. It's part of the Zoom. It's part of Zoom. I don't know if anybody has any ideas. I don't know how to make it go away. And if it went away, I wouldn't have any control over. Is it blocking anything?
Someone did say it's taking away from some text. It's probably a text or chat box open on her screen.
Well, no, it's the Zoom tool taskbar. So
turn off the live
I'm moving it around right
option.
now, right?
How about someone is saying, turn off the live transcript option.
I wouldn't even, any idea where that is. Disabled, annotation, hide names, show video panel. Yeah, I'm sorry. I don't know what to do about that right now. Nobody's ever brought that up.
Here, let's turn on, okay, under the view options usually. Yeah. Let's see.
The only thing I can think of is putting it at the top because these are just titles, but I don't know if that's going to help either.
I think it's okay. We can move forward. There was also another comment that possibly the viewer can change the zoom setting or maximize the window so that they can see all of the text.
And where?
So Paula, if I do have it full screen and I can see all the text, so that's maybe an option for the viewer.
Okay, that would be great.
Yeah. So
yeah,
we can.
I'll work on this off time. I've been doing these presentations and nobody's ever brought it up. So I can work on it. I guess maybe now's not the time because I wouldn't want to be amygdala hijacked and then not be able to access my prefrontal cortex that's holding all this lovely information.
Sounds great.
Which does happen when I'm doing presentations. So are we okay? Do you think that would be a good solution if they could?
Yeah, I think for now that sounds
okay.
It sounds like, yes, let's just move forward with that. Sounds good.
Okay.
Thank you.
All right, great. Okay, so like I said, we're going to be running into some dissociation slides here just in the beginning. I want to go over once again, dissociative states are they are states that are adaptive responses to trauma, and that there are three categories that we look at when we're looking at dissociation. One is derealisation, which is just escaping reality. One is depersonalization, when you feel detached from self. And then one is amnesia, which is basically lacking memory outside of normal consciousness. We've played this video in part one. We're going to play it again because it's so good. It's just a couple of minutes. So I'm just going to go ahead and start it. If there's any problems, just go ahead and let me know. Or not.
Hey, Psych2Goers. Do you feel distant from your emotions, thoughts, surroundings, and memories? This is part of something called dissociation. Dissociation is a defense mechanism where you unconsciously push away conflicting or threatening emotions and compartmentalize feelings so that you don't have to deal with them. Within the umbrella of dissociative symptoms, there are two that help categorize the experience: detachment dissociation and compartmentalization dissociation. Detachment dissociation refers to feeling like you have been taken out of your body. Compartmentalization dissociation refers to when your mind pushes aside distressing moments or experiences. This usually results in memory loss. With that said, here are 5 signs you may be experiencing dissociation. Number 1, memory loss. Memory loss is a common symptom of dissociation. You may find yourself at work or school, but unable to remember how you got there. Memory loss is one of the quickest symptoms to identify because it's obvious. The main reason memory loss goes hand in hand with dissociation is because your brain cannot handle whatever is going on, so it switches to autopilot. Dissociation pulls you outside of your body. Hence, it's difficult for you to remember what happens around you if you're not there. But these moments of dissociation don't always occur when we are frightened or distressed. They could sometimes happen while you're doing something. Number 2, derealisation. Derealisation is another symptom of dissociation. It sometimes feels like a dream where things are colorless, dull, or blurry. Derealisation is distressing and can cause anxiety, but it's common for those with anxiety, depression, and other mental illnesses. However, derealisation differs from other psychotic disorder symptoms in the sense that there is a degree of awareness. You are aware of reality and the feeling that distances you from it. Number 3, feeling lightheaded. There are many reasons why you may feel lightheaded, but in the context of mental health, dissociation can be a cause. When lightheadedness is paired with another one of the symptoms mentioned above, then the cause is most likely dissociation. The vestibular system is a sensory system responsible for spatial awareness and sense of balance. However, when you dissociate, you are not aware of your surroundings. When you come to, the sudden realization of your surroundings serves almost as vestibular stimulation and makes you lightheaded. Number 4, not feeling pain. Another sign of dissociation is not feeling pain. There is research suggesting that dissociation not only minimizes painful memories, but also the physical pain attached to them. However, the connection between dissociation and pain is not solely related to trauma. People who experience chronic pain can also experience dissociation. For some who experience dissociation as a result of a mental health condition, the feeling of not feeling in your body can sometimes lead you to self-injure. Although it makes sense to do something to bring you back into your body, self-injury is not the best option. And number 5, a loss of self-identity. Another aspect of dissociation is depersonalization. It's similar to derealisation in the sense that you feel like you are watching yourself. However, depersonalization makes you feel distant from your mental process. You feel that you're an observer of your own life. Depersonalization can occur with other symptoms on this list. It can be a very scary feeling, like you don't have any control over your body. Some clinicians believe that extreme stress or trauma can produce depersonalization. So, do you relate to any of these signs? Dissociation can be frightening and, in some cases, intrusive. It's not like a physical illness where diagnosis and treatment are administered via exams. But there is treatment, among them being psychotherapy, medication, family therapy, and clinical hypnosis. If you experience any of these symptoms, please reach out to a medical health professional for treatment. Please like and share this with friends that might find some good advice in the video as well. Make sure to subscribe to Psych2Go and hit the notification bell for more content. All the references used are added in the description box below. Thanks so much for watching, and we'll see you next time.
Excellent. So I love that video. It's short, it's sweet, it gets right to the point. I like to also show my clients that video so that we can really start breaking down what dissociation is, because knowledge is power, and we want to not only empower our clients, but empower the relationship we have by starting to give dissociation language. It's important that I introduce Dr. George Fraser, because he basically, the two tools that I use the most in my work came from him. So he wrote a paper back in 2003 that got awards, Fraser's Dissociative Table Technique. And basically this is a way to set up a conference room table in which you can start working with different aspects of client self. Because when we talk about dissociation, we talk about the client fragmenting into different conscious energies. And so as therapist and client, we want to get to know those therapies. And so he gave us this great tool that we can use. It's called Dissociative Table Technique. It's called Conference Room. It's called Meeting Place. And I said that I was going to introduce parts in our talk today. And so this is where we literally get to have and engage with our different parts of self. The other thing that Dr. Fraser did was put together the color-coded DS, which is a screening tool that we talked about in part 1 that I'm going to just touch on again in part 2, because it's an invaluable tool. He used it and color-coded it for his students because he's a professor. We're using it now because we as therapists can learn from our clients using the DS, not only as a screening tool around what our treatment plan is going to look like and what our client's clinical landscape is going to look like, but also it teaches us about the different aspects of dissociation at the same time, because he color coded it according to those different aspects. If you're looking for a great book to start with and you want to learn about trauma and dissociation, I love Sandra Paulson because she's a cartoonist and I'm a visual learner. Like I said, I'm dyslexic, so I literally hate reading. And I love Sandra's book because I literally go through and color it. I have this page copied and I color it with my clients to give them an idea of what a conference room or Fraser's dissociative table technique would look like. And so I'm just going to go over this with you real quick because it's going to hone in on some of the things that we're going to talk about today. So basically, like I said, Sandra Paulson does these great cartoons to help with learning. And this is a picture of Fraser's dissociative table, also known as meeting place, also known as conference room. And the idea is that different parts or aspects or energies of the client's self are all going to meet together. And in this meeting place, what all of these things allow us to do are going to be the four like mantras, I would say, for working with dissociation. It helps us fractionate, it helps us titrate, it helps us pendulate, and it helps us educate. And so that's what we're going to be focusing on in this part 2. And so just some examples are, you have a container in the middle where we can contain memories. We have this library vault in the back. My particular library vault has a huge lock on it where you need a code to get in. And in the library are going to be all the memories from the client's life. We have a room for children to go play in, children parts, young parts that don't necessarily want to be around to hear about some of the trauma work that we're going to be doing. We have a rocking chair for nurturing. My particular conference room has a living room area with Netflix and a little fridge. So you get to create with your client however you want your conference room to look. And this would be considered like a place for aspects of self to meet. And another type of language that we can use is maybe getting to know the client's inner family. So when we talk about parts work, and we talk about doing dissociative table work, just know that there's a lot of different language out there, and there are a lot of different teachers. And so you're going to hear about internal family systems, IFS. You're going to hear about Robin Shapiro. She does some great ego state work. You're going to hear about structural dissociation. So it's, I don't want to say everybody's not on the same page about it, but it's just different learning. And so I actually come from a transactional analysis background just to get things really confusing. But all I want you to pick up from today is that there are many ways that we can start to learn to work with dissociation by looking into the different aspects, the different energies of a client. So when we look at the measuring dissociation, all of us, no matter what type of therapist you are, should know how to use the DES, the Dissociative Experiences Scale. The fact that we have a screening tool that not only tells us if what kind of treatment plan we need for our client, which we'll talk about in a few minutes, but also it gives us language and our clients' language around what they're experiencing. The DES was not originally put together by Fraser, but he's the one that went in and, like I said, created this, created the color coded so that we could understand the questions that are used in the DES with our clients. This is an example of the DES, and you can go to my website, emdrchicago.com, under resources, under dissociation, and find yourself your own copy. And there are 28 questions. And like I said, this is the screening tool that we all use in order to understand our client's level of dissociation. Each question is color coded, because there are 5 different aspects of dissociation that we want to honor and to understand. We're going to talk about them in a minute, but just to introduce them, the yellow is going to be an absorption category. And absorption is an aspect of dissociation that we all experience. It's like driving down the street, planning on going to the mall and forgetting that you missed the exit because you were thinking about something else. It's watching a TV program and maybe not hearing like the microwave was done in the background. But when we get into these other categories, pink is amnesia, which would be lack of memory. Green, derealisation, depersonalisation, a really important aspect of dissociation, which we're going to talk about. Fantasy prone, a client's ability to just kind of snap into a fantasy. And then here's our ego states and our parts work. And so if you have a client that's scoring high within a certain color, you're going to start knowing the different aspects that the client is utilizing as their way to dissociate. And once again, dissociation is an adaptive coping strategy for clients that have experienced a lot of trauma. So Dr. George Fraser, who I also email, says, quote unquote, he shares the color coding of the 5 divisions, roughly reflecting the role of dissociation in the client's life. Once again, yellow is absorption, which is something that most people will experience. But when we get to the green, we're talking about depersonalization and derealization. These are higher ranking dissociative symptoms, and we need to literally understand how the client's experiencing it. And then once again, amnesia is going to be another very large red flag, because if you have a client that doesn't have memories of blocks of time, there's probably a reason for that. And that reason would most likely be that they were experiencing trauma that was too intense for their where they were developmentally. Okay, and we call that developmental trauma. The fantasy prone phenomenon, I think, is kind of cool. It's how a client can literally hallucinate on demand. So I have a client that walks down the hall of school where she works, and she literally can put herself on a mountain and can snowboard. So, I mean, that's a drastic example, but fantasy is used quite a bit. It's the way clients put themselves to sleep. It's the way clients, I had one client who there was a lot of domestic violence going on in the home. And when mom and dad would start yelling at each other, she'd go into her room and work with her dollhouse where her real family was. So fantasy, once again, we want to know what those fantasy prone questions are, because if the client is able to fantasize, that's something that we as therapists need to know to understand the client's clinical landscape. And then last but not least are going to be those blue states, which are going to be the ego states. Once again, this is where we get into parts work. You're going to hear a lot of therapists refer to doing parts work. It's important to understand the different aspects of self, the different parts of self, the different energies of self. And I'm not going to give it away because I'm going to show you an inner family in a minute, but it's really powerful work that you can do. So let's look at derealization, depersonalization, and amnesia first, because these are the 2 main categories. When we look at PTSD as a diagnosis, this is something I'm kind of like working on right now, but PTSD as a diagnosis many years ago didn't have dissociation as a subtype, but now it does. And that subtype is it's when we see derealization, depersonalization, and amnesia. A tool like EMDR, for example, and there are many tools out there. I just happen to be an EMDR therapist. We talk about how EMDR is 85% effective with PTSD. My question is it PTSD from today, where you have a dissociative subtype that includes derealization, depersonalization, and amnesia? Or are we talking about PTSD that was 2 DSMs ago, where dissociation wasn't a subtype? This is a very good question, and is something that we need to answer. But if you're doing your DES with your client, at the end of the day, you're doing your due diligence in understanding if amnesia and derealization and depersonalization are in fact something that your client's experiencing. The first category, which was the derealization, depersonalization, is a detachment. It's an altered state of consciousness characterized by a sense of separation. So the client is literally taking that trauma time and separating it out so that the client can function maybe during the day going to school, but then coming home and having to deal with an alcoholic environment, domestic violent environment. The different aspects of self can basically exist on their own. Examples of detachment, which are going to be the depersonalization and derealization, is for depersonalization, it is not in one's body, being out of the body. The client can say, I was outside of my body and I could not feel my legs. And the derealization example is, it didn't happen to me. It didn't happen to me. I could see it happening, but it was not happening to me. When we get high scores on the DES, especially high scores, we do the next, it's not a screening tool, it's a diagnostic tool, but we look at dissociative disorders, and dissociative disorders are pretty intense. And we do what's called the multidimensional inventory of dissociation. If you want to take a look at it, that's also on my website. I don't recommend venturing into it just yet if this is new to you, but the questions, the type of questions that are on the multidimensional inventory of dissociation are literally questions that can give you language specifically for what your client's experiencing. And I just think that going over some of these statements, these questions that the clients are experiencing is going to help you get an understanding of what these words really mean. Took me a long time to understand it, so I figured maybe if I could consolidate it, it would be a little bit easier for you. So once again, we're looking at these green questions on the DS that are derealization, depersonalization. Depersonalization are things like feeling like you are inside of yourself watching what you are doing. Your mind is blocking and going totally empty. You're standing outside of your body watching yourself. You're feeling detached from your behavior, like you're going through the motions, feeling like you're only partially there and not really there, feeling as if your body is unreal. My client will say, and she's highly dissociative, and I did not know this when she first walked in my door, she will say, only my leg is talking to you right now. Now, you can imagine back in the day, I was like, what? But now only her leg is sharing with me because the rest of her body is not present. And the rest of her body is not present because it needs to disconnect itself due to the trauma material that it holds. And so when our clients start to use this type of language with us, well, once again, it's giving you data. Hear my science background, data around the client's clinical landscape. So if your client feels that a part of their body is not there with you in the room, that's something that not only do you want to know as a therapist, but you want your client to be comfortable sharing that with you. Derealization, some examples. Once again, this is where it's not real. Feeling like your surroundings are fading away. Feeling like time is slowing down. Feeling like things are changing, sizes and shapes. Feeling that other people, objects of the world around you are not real. Being in familiar places, but feeling that they're strange. Things around you seem strange. And so what I'm doing here is I'm actually taking the questions from the DES, and they're the green questions, because once again, we've got the color coded. And this is literally what the client would be saying. Yes, I feel like I'm standing next to myself 80% of the time. When I look in the mirror, I don't recognize myself. If your client is experiencing that more than 30% of the time, that's something you're going to want to know, that you're going to have a conversation about. Tell me what that looks like. What is it that you see in the mirror? How long has this been happening? Having the experience of feeling that other people's objects or the world around them are not real. Having the experience of feeling that your body does not belong to them. If my client is feeling that their body does not belong to them, that is going to change my treatment plan, because my first goal is going to be for my client to be able to experience their body. And that is not going to entail going in and talking about their trauma. Having experiences of being in a familiar place, but it feeling strange and unfamiliar, and feeling as if they are looking at the world through a fog. So these are the specific questions that you see on the DES, and they are the greenish blue questions. The second category that's super important when we're talking about dissociation is amnesia. The inability to bring normal, accessible, I hate the word normal, accessible information into conscious awareness. So the types of amnesia, once again, I'm going to go to the mid. I should put that on here. I'm going to the mid for language, is when a client experiences blackouts or blank spells in their memory. Of course, if they're experiencing blackouts, we're going to want to know if they're alcohol or induced or not. But at the end of the day, a blackout is a blackout, and a blackout when drinking is dissociative. Coming to, where a client suddenly wakes up in the middle of doing something. Fugue states, finding yourself somewhere and not remembering how you got there. Being told to disremember actions, being told of things that you have done and having no memory of them. Finding objects in your possessions and discovering a recent injury with no memory of how it got there. Once again, these questions are going to allow us to do an interview with the client, because if I have an 80% for a client finding possessions that they don't remember where they got them, I'm going to say, can you tell me a little bit about that? And the client may say, oh my gosh, I'm finding Amazon packages everywhere. And I want to say, well, who isn't? Especially in the last 2 years. But if the client says that there were groceries on their counter and they have absolutely no idea where they came from and they don't remember purchasing them, that's going to be something that I'm going to want to know more about. How often does that happen? What are other examples? How far back does that go? How disruptive is that for you in your life? So dissociation, the specific questions on the DS are finding oneself in a place or having no idea how they got there, having no memory for some important events in their life. You're going to get clients that are going to say, oh, I don't remember all my birthday parties, or I don't remember my college graduation. That's fine. We're normalizing, and maybe they are doing that 20% of the time, 30% of the time. But if it's 80% of the time, there's a good chance you might be delving into a client who has no memory from the ages of 5 to 12. My one client that came in that I did not know much about told me she had no memories under the age of 12. That is a major red flag. Finding evidence that they have done things that they do not remember doing. So those are going to be the 3 questions that are going to be on the DS. And so just once again, looking at how we've got our derealization, depersonalization questions here in these greens. We've got the amnesia questions in the pink. We've got once the absorption, which is something that we that should be something that our clients are experiencing every day, because so do we. And then we have the blue, which is going to be our parts work. And then fantasy prone is thrown in there in the orange. It's not a dissociation. If it was the only type of dissociation the client was experiencing, it's not something that would lead us to thinking about a dissociative diagnosis. Okay, the derealization, the depersonalization, and the amnesia are going to be what we're looking at to think maybe I need to do that, take that next step in order to find out if my client is dissociative and needs a dissociative diagnosis, as opposed to just a PTSD diagnosis or whatever diagnosis, anxiety, depression, etc. Trying to think if there's anything else here. There was one other piece just to elaborate a little bit more on the DS than I did last time. The first 2 questions are something that all of us experience. Like I said, I think one of them has to do with driving. The other one has to do with watching TV. If there are zeros there, just know that there's it's suspect that the client may not be engaged in doing the DS. And if you see a lot of the blue questions with high scores, the ego states, we want to take into consideration that there's going to be a part of self that's probably going to show up and is not going to want to do the work. So so usually the ego states are something that are going to show up front and center and may not want to do the DS, or may think the DS is stupid. And you're just going to see a lot of zeros going down the all 28 questions. Or like I said, you're going to have you're going to see that specifically when you see that in the absorption questions. And once again, this is about collecting data on our clients. This is not a fail by any means. This is going to be a okay, let's talk about this. So when you're driving down the street or when you are watching TV, you've never experienced some sort of distraction. It's just, once again, the clinical interview that comes with this very basic screening tool is a really big aspect of you understanding what your treatment plan is going to look like. Okay, so just to kind of wrap this up, what do we do next? If you have a DES score of over 20, you want to conduct the clinical interview. Even if you have a DES score of under 20, but you have one or two questions that have like a 50 or a 60, let's go in there and ask that client to give us an explanation of what it is that they experience. Because once again, you're only helping yourself by giving yourself better data, and you're giving the client language to explain what these experiences are like for them. So then moving on,
Hey,
here's your
Paula.
name. Yeah.
Paula, I'm sorry to interrupt. There are several questions about the DES. Would you like to answer those now or wait
Sure.
until?
Yeah.
Okay.
No, that's a great idea. Let's see.
Okay, so let's start in the Q&A. So I guess there's several questions about if there is a link to the actual DES.
Yes, it's on my website, EMDR
Perfect.
Chicago, under resources, under dissociation. There's a link for the DS for children, for adolescents, for adults, the color coded, and there's the mid access. If you want to see what that looks like, you can reach out to Paul Dell and he'll send you a copy.
Okay, perfect. And then one question was that at the top of this, it says that it is not intended for clients. That is just because the color coded version is not intended for clients. However,
Exactly.
Yes.
That's
okay.
Yes, that's Dr. Frazier saying, I actually put this together for my students. It's totally up to you how you want to do it. If you want to use the color coded or use a black and white version and then just transfer it over.
Okay. And then where does fantasy rank within dissociation compared to depersonalization, derealisation, or amnesia?
I love it. These are all great questions. So fantasy is going to be lower on the importance scale. When we are thinking about clients that, let's say, come in with what we're giving them a PTSD diagnosis, it's going to be the derealization, the depersonalization, and the amnesia that are going to be the key components. So fantasy is important. And Dr. Frazier comes from a hypnosis background, and trance states are important to understand for clients. But does it rank importance? No. I mean, I'm not saying it's not important. I'm just saying if you're looking at the level of importance, it's going to be the derealization, depersonalization, and amnesia that come first.
Okay. And then how do you differentiate amnesia versus memory loss due to aging?
You know, that is a good question. The only reason why I'm stopping on that question is because I've never been asked it before, and I don't like to answer questions that I don't know the answer to. So I'm going to leave that question out there. I have to think about that because I just don't want to give you the wrong answer. I mean, I think there's probably an answer because, but no, I'm not going to go there just now. So just put a little asterisk next to that question for me.
Okay. Is temporary loss of knowledge also an example of amnesia?
Yes, that would be time loss in current time. Yep.
Does amnesia include disassociated rage when they get so angry they black out?
Yes.
Okay. The link, let's see. Some of these are probably more for the end. I'm just trying to with the DES. Are there some good strategies that you use to differentiate between trauma-related dissociation and perhaps other contributing factors like a TBI or neurological issues when using the DES?
Yeah, so I would refer you on my website under coaches. I would refer you to Eric Brummer. He's our TBI brain specialist, and he is very specific around talking about dissociation and TBIs.
Okay, great.
So you can just reach out to him. Yeah.
And again, the DES is on Paula's website. What is meant by importance in ranking?
Oh, what you want to prioritize as far as what can be get in the way of the client's functioning. So, for example, if I have a score of, let's say I take my 28 questions and I take all the totals, add it up, divide it by 28, and I have about a 45, let's say. If all of my yellow questions are, 60, 70, and 80, the absorption questions, I'm still going to do the interview, but I'm not really going to think about doing maybe the next step to see if there's a dissociation diagnosis. But if I have a lot of the green questions, derealization, depersonalization, and a lot of the pink questions, I probably will take into consideration taking that next step. If I have a lot of blue questions, I'm definitely going to want to start parts work and maybe set up that meeting place that we looked at, because the client is familiar with and can put language to their parts. Does that answer the question?
Great, yes. And then I found that a client with ADHD scored above 20% on a few items on DES that relate to attention forgetfulness, but doesn't report trauma. Is that something you see happen sometimes? Any recommendations on differentiation?
Yeah, so we're seeing a lot of overlap between ADHD and trauma. I just really recently posted, if you want to get a copy of my newsletter or go on to LinkedIn, I posted a article on this just recently. And so what I would recommend is reading the article, because it's very specific about the differences and then what the overlap looks like. I mean, it's going to be interesting to see how many of our ADHD kids actually have trauma and how many of them don't. But it's very specific as to what the symptoms are that are in both ADHD and trauma, what's just ADHD and what's just trauma.
Okay, great. And then there's just one more. Please address number 10 about lying.
Number 10, hold on.
So I can read it too. It says some people have experience of being accused of lying when they do not think they have lied. Circle a number to show what percentage of the time this happens to you.
Yes, so that would be parts work, and that would be an example of a client maybe having two parts that aren't exactly co-conscious, and one part's doing something and the other part doesn't necessarily know it. And then that other part is being accused of or said that they said something different. That would be a very good example of why you would want to start with parts work with that client.
Great. Okay. And then the person that you referenced for the TBI patients is Eric Brummer, correct?
Yes. Mm-hmm.
Okay.
Okay. And then if you need the article, just email me at emdrchicago@gmail.com and I'll send you the newsletter. Jump on my newsletter list, because I send the most popular articles on LinkedIn. I do a lot of posting on LinkedIn, and that article got 3,000, what do you call it? It's not likes, but anyway, I put the most popular articles and that was one of them.
Okay. Actually, Paula, there's a couple more. How do you differentiate actual dissociative experiences described in number 10 on the DES from someone who is accused of lying by an abuser or someone gaslighting them?
It's the same thing. It really is. It's the part of self that either is mimicking the abuser, mimicking the narcissist, mimicking the gaslighter. It's all parts work. Every aspect of ourselves is a part, and a part that lies is lying for some adaptive reason. And as a therapist, it is our job to find out what that part, why it's lying and how it's protecting that client, because all our parts are in service of our own survival. Wonderful.
And then does the DES come in Spanish? Is it available on your website in Spanish? Or
no, it's not. Let me look into that. I'll reach out to Robert Merucci for that one. That's a good one. Good.
And then also any other material about disassociation in Spanish.
Okay. Yes, I've been asked. Okay, I got it. I will work on that.
Okay. And then going back to the gaslighting question, they followed up saying, I meant, what if a person is actively being gaslit? They're not really lying, but they're being gaslit.
Well, that would have been the second most popular article on LinkedIn this month. And so there's a really good article on that in my newsletter as well. Once again, it's all going to be part of parts work, because if they're being gaslit, then there is going to be a part of them that thinks that way. And so you're going to be, well, here we're getting into case consultation here, but basically we're going to be working on their side of the street where you have the gaslighter. You can't change people, places, things, but you are going to be working with the client themselves and how they can recognize gaslighting and how do they want to deal with that. I'm not sure if that's going to answer the question, but that's the best I can do for right now.
Okay, great. And then there's other questions a lot surrounding ADHD, but we can get to that.
Yeah, let's move on. Let's move
okay.
on. I want to make sure
Sounds
I get to
good.
everything, and then we'll have time hopefully at the end. Okay, great. But I'm very excited. The questions were wonderful. Means you're engaged and that you're listening. And so Pierre Genet goes back into the late 1800s. He is like our grandfather of trauma. Between Pierre Genet and Jung and Judith Herman, we've got a lot of great learning going on around what dissociation is. And so Pierre Genet describes dissociation as a defensive response to acute trauma. That makes sense. Acute trauma can be anything in the moment that is traumatizing, which means that it could be anything from the past as well, because the past is present. That's what trauma is. So it doesn't matter what the event is, it's how you respond to it. One of my favorite books right now is with Oprah Winfrey and Bruce Perry, talking about, what happened to you. And it's lovely because you want to get it in audio, because you can hear Oprah asking Bruce questions, and she had a pretty traumatic past. And she talks about how it shows up present day. And he does a really nice job of talking about how that works with the brain. So our acute trauma is going to be anything that goes back into the past, even in utero. That's a whole other piece. But and then according to this view, dissociation is going to be the failure of the memory system due to how emotional or intense the arousal was at the time of the trauma. So we're going to be looking at clients developmentally. Like I said, we call it developmental trauma as well, because if a client, generally child abuse happens between the ages of 5 and 12, and developmentally, you're going to have some developmental delays because the client is going to be working on survival and not necessarily being able to develop in an appropriate way. So some individuals are not able to process and integrate. And that would be due to the fact that they have been spending the majority of their time trying to survive. And so, leaving that window of tolerance, not being able to be in that zone of arousal means that they cannot integrate appropriately their experiences, their external and internal experiences. So what do we need to do as therapists? Well, dual attention. And when I say dual attention, that means that the client has literally one foot in the trauma memory and one foot present day with us here today. We talk about dual attention a lot in EMDR therapy because it's important for us to make sure that our client is also with the memory and us and not just in the memory. So adult perspective memory networks would be about like what is going on in the client's moment. If it's like securing their personal space, if you're doing online work, or securing their space in your office, or being able to talk about something that happened with their dog that morning, that would be present time orientation. And then also being able to access whatever that memory is, visiting it with you. So the key is that if the client leaves their window of tolerance, if the client zone of arousal is so intense that it makes them, it puts them in a space where they cannot receive information. Oh, did I spell receive right? Yeah. Receive information, process the information, and then integrate the information, then you're going to have all kinds of problems. And, we use BASC, and I actually put a C in here. We use BASC because all of these things can be affected by dissociation: a client's behavior, a client's affect, sensations, consciousness, knowledge, and some kind of crazy examples. Let's go to sensations. So one of my clients has non-epileptic seizures. And so that's the trauma stored in her body. So when we access the trauma memories, she's leaving her window of tolerance. She's not, the arousal is too intense for her. And she doesn't have language for the experience because it happened during a nonverbal time of her life. And so it comes out physically in what looks like seizures. They're not epileptic, so they're not dangerous in that way. But, you know, as a therapist, you've got to know what to do with this. Numbing is another one. Your client can sit there and tell you all about this horrific trauma, and yet it doesn't look like they're feeling a thing. We've got behavior. Just once again, I'm going to throw some of the more interesting ones in. I've never experienced a client that's gone blind, but I've heard of clients that have gone blind. I've heard of clients that have become mute. And all of this would be due to them experiencing the result of this inability to integrate. And then we've got our depersonalization, derealisation as part of consciousness. And then we have our knowledge cognitions, which is going to be amnesia. And a big one that we work with EMDR is negative beliefs. This belief about self, self-confidence, self-esteem, feeling that you're unlovable, you're worthless, you're invisible, you're unimportant. We get a lot of these messages that come with these clients. So dissociation is the opposite of mindfulness. It is the opposite of present time orientation. So as we move into our tools and what we're going to be, things that we can do to assist with helping our client stay mindful, stay present, keeping one foot in the present with us, the therapist, while the other foot is in the trauma memory with of which the therapist or the client is visiting. And the language I like to use with the clients is, I want to visit the trauma memory with you. I don't want you to go alone and I relive the trauma memory, but I need you to be here with me and visiting the memory. So when we're talking about trauma work, the keys here, call it the mantras, are about fractionating memories, titrating memories, pendulating memories, and educating about memories. And the tools are all going to be utilizing one of these or many of these in some way, shape, or form. So what does that look like? And we're going to go over them, and then I'm going to give you some examples. So when we talk about the window of tolerance, the material will need to be, like I said, titrated, fractionated, pendulated. You want to give the client knowledge about past, present connections. You want to give them language. So my client that I was working with yesterday came in and said, this is what happened. I was absolutely furious. And my go-to for my clients are, what's the past, present connection? That's language that I've taught them. That's language that I need them to understand, because, and you'll see this in a minute, but the 20-80 rule is 20% of what happens to you is about today, and 80% comes from the past. And once we're able to identify that past, then we can understand why we are leaving our window of tolerance to begin with. And then we can also start thinking about how we can get back into our window of tolerance by taking whatever that 80% is and breaking it into pieces, fractionating it, or diluting it, titrating it, or and pendulating it, which means we're going to teach them how to shift from a present space into a trauma space. Richard Clough, who is a big academic, and he has contributed a lot to our field, says slower is always faster in working with dissociative clients. And it's true. When I first became a trauma therapist, I was under the impression that if you talked about the memories, then we're all good. And that my goal was to see if you could talk about the memories. I'm really good at speaking, and I did great work of bringing my clients' trauma work into the room. And then they became overactivated, shut down, dissociative. And then I was like, well, now what? So slower is faster. my consultants are constantly, even to this day, telling me to slow down. And you can tell I'm a fast talker, I'm a fast thinker, I'm kind of like that personality. And I've learned a lot about being mindful, being present, and slowing the work down. My favorite consultant, I get consultation from Deanie Laliotis, and she says we need to do the work before the work. And the work before the work is going to be some of the learning that we're going to move into right now. So, oh, this is perfect. So when we ended our part one, this is what we ended with. We ended with, okay, we're going to learn to fractionate, titrate, pendulate, and educate. And these are some examples of things that we could do, but we didn't go over how to do them. So that's what I'm here for today, mainly. And so what we're going to start with is, and most of you will have an understanding of this, but I'm going to elaborate on it. The window of tolerance, we're talking about emotional regulation, and it should say, and parts education. And so what does that look like? Well, actually, yes. Okay, let's do it that way. All right. So the window of tolerance, talking about emotional regulation. Our window of tolerance is our zone of arousal. It is our ability to hold the emotions and sensations and beliefs of an experience. And if that zone of arousal is not being contained, then the client cannot receive, process, or integrate whatever it is that you're talking about. Looks like I have to clean up this slide. The 4 mantras that I like to use with my client as I'm going into the psychoeducation around window of tolerance and emotional regulation is, we want to learn to name it to tame it, Daniel Siegel. That half of change is acknowledgement. So we want to put language to what that change is going to look like. That knowledge is power. So I want to constantly be empowering my client with the knowledge of what the window of tolerance is, what are the different states that we can be shifting into, and then that 20-80 rule. If you come in and tell me about something horrific that happened today, then what is that 80%? Where does it come from? And that's going to be part of half of change is acknowledgement, because that 80% is literally where our work needs to be. Yeah, I've got receive spelled many different ways. So window of tolerance, our zone of arousal, our client's ability to merge information, to consolidate memories. So if I am terrified of dogs because a dog bit me in the face when I was younger, and it's true, a dog did, and I see a dog, it's going to be very difficult for my brain to receive the information, to process the information, and to integrate it into my other memories of dogs because I had a traumatic experience. And so what happens instead is I'm activated and triggered to that 5-year-old self that was bit by a dog, and I am not able to consolidate and merge current information. And if I become too dysregulated, it's going to get in the way of my functioning. And so that's why it's important for us to know and for us to teach our clients about how their internal and external experiences leads to this ability to integrate this information or not. Understanding the window of tolerance can be helpful when working with the clients, because we as therapists are always on what's called the windowsill. This is Kathy Martin's language. It's like a very fine line, especially when I'm doing my EMDR trainings and I'm saying, oh, you better make sure your client doesn't leave that window of tolerance, but you're going to be right there on the edge all the time because that's your job. Clients slide in and out of the window of tolerance, and we just need to have the tools and have the client have tools in order for them to be able to shift states back into their window. This is the chart. You know, I love my LinkedIn account. I've got like 12,000 people on it or something. And I love to put out like, which chart do you like best? Because there's a number of window of tolerance charts. And this is the one that came in number 1. And so this is the one I use in my presentation. And so this window of tolerance visual gives us a really good way to work with our clients around understanding when they leave their comfort zone, when they leave their ability to self-soothe, their ability to regulate their own states, what exactly is happening for them. So they're on the windowsill of tolerance right here. And then, I don't know if you can see it doesn't matter. And then as we shift into a hyper aroused state, what does that look like? We're experiencing anxiety, we're being overwhelmed, we're feeling maybe angry, or we've got outbursts of emotion. There's a lot of energy with a hyper aroused state. And then and I bet this bar is covering it, the hypo aroused state, where you've got disconnection. And this is where our dissociation is. This is where the client's unavailable and shut down and experiencing memory loss. And so we want to give language to that. We want the client to understand when they're moving into one state or the other. And then we want to have a conversation around how are you able to then shift back into your window of tolerance. Well, this is where, hold on. So this is where polyvagal comes in. But before we talk about polyvagal, I want to introduce one of the ways that I use to explain to clients their shifting from one state to another. And we were talking a little bit about how there's different types of parts work. There's internal family systems. There is structural dissociation with what's called the apparently normal part and the emotional part. And then, like I said, I come from a transactional analysis background. And the transactional analysis background basically says that we all have parts, and we start with a clean slate, and those parts evolve out of our family system and our environment that we grow up in. So of course, there's going to be intergenerational trauma. There's all sorts of components that are added to that. But learning your family, your inner family, is a great way to start utilizing the language around window of tolerance, because our different parts of self can engage in different states. And so what I threw in here, just as an introduction, is an example of an inner family. I do this with all of my clients. This is part of my stabilization. And what transactional analysis tells us is that every single one of us have an adult part, have a free part, have a nurturing part, have an adaptive part, and have a critical part. Some of you that have worked with me know your own your inner families, because I have you do this. But literally, transactional analysis gives us the language that we pick from for each part of self. So this particular adult part, their name is Christian. Makes sense. We ask how old. It's 23 years old, and it's responsible and makes good choices. And then this free part is the part that looks like music and dancing. The nurturing part looks like they're just loving. The adaptive part is actually a bear, and this is a cave where the bear likes to go in and hide and get away from people. And then we have a critical part here, which is the controlling part, which is going to be where you're going to find some judgmental and negative energy. And so it's important for the clients to understand their different aspects of self, their different parts of self, whatever language you want to use, because then the client can talk about, well, my controlling critical part got really upset. And then we can start talking about, well, did they become hyper aroused? And what does your adult part have to say about that? So this is just an example. And I said that I was going to do an intro to parts work. And what I'm doing is integrating different ways that we can be using parts as we go forward. So I feel very strongly about moving from the window of tolerance into polyvagal. For those of you that are polyvagal informed, I don't know how anybody does this work without understanding the polyvagal theory. Stephen Porges did a really nice job of working with Deb Dana like I said, Steven's the scientist. Deb is, she's the one that puts together, and I'll show you her books in a minute, but she has put together language that has really helped us as therapists understanding the autonomic nervous system. And yes, we have fight flight, and yes, we have a shutdown dissociative experience in our window of tolerance, but this is going on in our autonomic nervous system, and it is unconscious. We are not aware of the shifts, the state shifts that we're experiencing. And so if you have a client that has been, raped, for example, and they're beating themselves up because they didn't fight back, it's really important that they understand that neuroception is what made the decision for them, which is unconscious, and that they shifted into their dorsal vagal parasympathetic state, which means that their body shut down and that they were not going to fight. They were going to pretend they were dead so that they could survive the situation. So, okay, I kind of went in a little bit too deep there. But with that being said, let's look at polyvagal. This is like the window of tolerance. This is like the window of tolerance, but this is the chart that I like. I put it out on LinkedIn and nobody liked it, and that's okay. But I like this chart because it shows our state shifts in a different way. So when you think about this particular window of tolerance, it's got our hyper arousal at the top, and it's got our hypo arousal at the bottom. And that's lovely. But the way that it really works is that when you are in your window of connection, when you are able to be grounded, you're able to be present, you're in your window of tolerance. When you get triggered and you leave your window of tolerance, you go into the sympathetic nervous system. And it's not like the brain says, hey, I'm going into the sympathetic nervous system. I'm going to be in fight flight now, so be ready. Your heart rate's going to jump. Your blood pressure's going to jump. You're going to have a lot of adrenaline, and you're going to be ready to do all kinds of things. But I'm also not going to let you think right now, because we've got to figure out how to save ourselves. Okay, it's in service of survival. So you see all this language: rage, anger, irritation, frustration, anxiety, fear, panic. It all includes an increase in heart rate. When you get your heart rate above 110 beats per minute, you can't access the prefrontal cortex. You can't think about all those problem solving skills that maybe you learned in inpatient. So we need to teach our clients that when they're moving into fight flight, that they're basically getting ready to either fight or flight. If the danger doesn't go away, you have a trigger, like I said, bit by a dog, I see a dog, I go into fight flight, I get all pissed off because the dog isn't on a leash, and I'm like, what the heck is wrong with that guy? Why doesn't he put his dog on a leash? I'm in fight flight, I want to fight. If the dog doesn't go away, if the danger doesn't go away, my autonomic nervous system is going to then automatically move me into the dorsal vagal. And the dorsal vagal is a freeze. It is a sudden drop in heart rate. This is where Stephen Porges, and this is what my presentation is going to be on when I do polyvagal. Stephen Porges' polyvagal theory comes from heart rate variability. And the client's heart rate doesn't go back to resting rate if they're traumatized. It goes below resting rate. And so this is where you see a decrease in heart rate and blood pressure and body temperature and muscle tone. This is where the body becomes limp. And also there are opiates that are released, androgynous opiates, like that is heroin, folks. So a lot of clients really like being dissociative, shut down, numb, because they don't feel anything. But of course, it gets in the way of our functioning. Now, this all seems very simple, and it can be that simple when it comes to teaching, because what we like to do is help our clients give language to these different states of self, because they're able to identify for themselves how it works. And if you go onto, I'm not going to play this video, but if you go onto my website under resources, under polyvagal, This is Stephen Porges' son, Seth. He is a comedian. I personally thought he was pretty funny. I have my clients watch this video, and I would recommend that all of you as therapists watch this video. He does a fantastic job of explaining his father's theory, and the two of them are writing a book together right now. And so that's kind of fun. So that would be a great way for you to maybe venture into learning about polyvagal. When I do the presentation in April, I'm going to be pulling on Deb Dana's work and Seth's work, because Seth is the one who introduces us to the concept of the green zone, the yellow zone, and the red zone, which is exactly the chart that we're working with here. And so I'm pulling a couple slides from my polyvagal presentation, but when working with our clients, this is our ventral vagal state. This is what we call our green state. It is our state where we are in our window of tolerance. It is about social engagement. It's about having a regulated resting rate heartbeat. It's about our breathing, our muscles relax. And then as we move into the next state, because let's say we are engaged in a trigger, or we have a nightmare, or there's something that comes up in therapy, we move into the sympathetic nervous system. And the sympathetic state is more about being scared and having that heart rate increase. And we need to go into action, our fight or flight. And so, having a client be able to say, I was in my yellow state a lot this week. That's beautiful language. And then you can start talking about that yellow state. And then we talk about, well, how do you move from the yellow state into the green state? I like to listen to music. I like to go for walks. I like to get on my bike. This is us teaching our clients how to move from being dysregulated into being regulated. What happens for a lot of our clients, especially during the pandemic and those that have experienced trauma, is that when the danger doesn't go away, hence we had no idea if we were ever going to be able to leave our houses, and if in fact there was going to be a vaccine, we had a lot of clients and therapists go into their dorsal vagal parasympathetic state. And this is where the heart rate drops. This is where you kind of give up. It's like helpless, it's hopeless, it's exhausting, you're lethargic. And like I said, there are androgynous opiates that are released in your body, which create a sense of numbing. And so my one client, who's a PhD, and he says to me, I think I just go from yellow to red, yellow to red, yellow to red. And I love red, but that's when I'm laying on my couch, zoning out to Netflix, and I'm not getting anything done. And I'm like, okay, let's talk about that. So Deb Dana does a really nice job in her books. And I'll show you a picture of her books in a minute. She's got a number of books out on giving us what's called a polyvagal ladder worksheet that we can work with our clients. So here we've got our ventral vagal up here. We've got our sympathetic here, and we've got our dorsal vagal, because the client will go from being in their window of tolerance to then their hyper aroused fight flight, and then into their hypo aroused shutdown. And so we want the clients to be able to fill this ladder out. And so I put together this is the example I use with my clients. This would be something I did with my clients. Actually, this is the example that I use for them. But we take our markers and we do green, and we talk about different things that the client experiences when they're in their green state. There's going to be descriptors here, like I said, music, walking, biking, things that help the client be calm, present, regulated. And then we have these questions. The world is, this is all Deb Dana's work. When I'm in my ventral vagal safe connected state, and when I'm in my window of tolerance, the world is a wonderful place and I'm feeling good. And I gave it a cue word of love, because a lot of times our clients will refer to these things using their cue words. When I'm triggered and I start to get really panicky or upset, my heart rate's increasing and my blood pressure's increasing, and I'm becoming alert and I feel like I'm in danger and I'm tensing up, the world is a scary place for me and I'm terrified and I want to run and hide. And we gave that cue word the WTF. And then last but not least, if the danger doesn't go away and we're still terrified and we are not able to move into our ventral vagal calm, present, mindful place, our body is automatically, remember it's unconscious, the autonomic nervous system is going to move the client into the dorsal vagal, which is dissociation. And it is a drop in heart rate. And sometimes your clients will say they feel dizzy. Well, it's the heart rate drop that makes them dizzy. It's a blood pressure drop. It's once again, you've got the body shutting down. And this particular client said the world is a crappy place and that they feel hopeless and they just want to give up. And the cue word was leave me alone. So this is just an example of using polyvagal and window of tolerance as a way to give the clients language around state shifts, because we want our clients to be able to state shift. We want them to identify when they need to state shift, and we want them to be able to, everybody's going to be different. So not only do I want to know what moves me into yellow, dogs, what keeps me in yellow and moves me into red, the dog doesn't go away and it's still off its leash and it's getting closer to me. And what's going to take me back into being mindful and present, I'm going to call 311 and somebody's going to come and take care of the dog for me. Those are all fantastic conversations to have with your therapist. Also, there are, lots of fun things. The Purble, his name is Mark. I just got him. This is a fantastic toy for adults and kids. It has a heart rate and you have to be able to soothe it in order for its heart rate to go down, and it purrs and it like makes cute little gerbil noises. I don't know what gerbils say, but if you can't soothe it, its heart rate increases and it starts to vibrate and it gets very distressed. And so it's an excellent way to teach kids. And like I said, because my adults have a lot of kids' parts, they love it. And it says 95% of families reported that the Purble companion helped their child find calm when they needed to. And I use it in my office. There are other ways that we can use to ground our clients and move them into the green state. These are foam fruits. I finally found a use for one of those crystal bowls I got when I got married. These are nasal inhalers, and it's the fastest way to ground a client is through smell. And so especially when a client's at home, sometimes I'll have them go into their kitchen and find, garlic, cinnamon, onions, whatever it is. This is ways that we can help our clients figure out how to shift out of a distressing state. So that's kind of just a little bit on polyvagal that I wanted to throw in there. When I do the polyvagal presentation next month, I'm going to bring a lot more examples of ways that we can work with our clients and spend more time talking about the different states. So if you guys want to plan on being part of that polyvagal, I think we said it was April 20th. I think it's going to be 10 to 12 again. Get on there and watch Seth Borges's 30-minute video because that will be the greatest way for you to prepare for it. These are the books that she has out. I highly recommend everybody have this book in their library. And then we've got additional, there's 125, actually it says 50, but I'm pretty sure there's more than that. Separate exercises you can do. And then the flip chart is a great learning tool that we use for our clients. Okay, let's see here. Now, time. Okay, we're going to talk about picture-in-picture next. We've got 2 out of 5 of these down. Picture-in-picture is from Joanne Twombly. And we're talking about ways to fractionate, titrate, pendulate, educate. And picture-in-picture is going to especially use pendulation. It's going to use titration, and it's going to use fractionation. I guess it's going to use all 4. So let's see how this works. So when you're doing a picture-in-picture, the key is that we are going to fractionate by picking one aspect of a memory. So if a client comes in and said they're having flashbacks around a sexual abuse experience, and they can just see the face of the perpetrator over and over and over again, then that would be an example of taking a very small piece of the whole experience. That would be fractionating. And then what we want to do with this client is we're going to be using screens. It's picture in picture. So we've got these really beautiful, elaborate TV screens that we use now. And we're going to take that large screen, and that's where we're going to put the client's imagery, calm place imagery, something that you've worked with them on in the past. I know with EMDR, we have specific protocols for securing spaces and imagery around hikes or sunsets or whatever it is that calms the client, but it's going to be visualization. And I know the question comes up, if they can't visualize, then this is not necessarily going to be the right exercise done this way, even though I do believe in having those clients bring in pictures or doing collages. So the client then is going to take the small picture, the picture in picture, the small picture of the face as being the disturbing memory. And so what we do is we start with the large picture, which is going to be, in this particular example, a hike. And then we're going to have the client have a remote control. And the remote control is going to be totally the client's ability to titrate. So we can make the picture small, we can make the picture a little bigger, we can make the picture far away, we can make the picture go away, we can turn the remote off. And this is all going to be them having control over the small picture that's involved. So the point is, like, get creative. And so I have an example here. So the example is that the client's large screen, the calm place is a hike. And it's green, it's lush, it's quiet, it's hearing birds, the wind, feeling the breeze, smelling the forest, drinking water, feeling good, exercising. And so, like, the client literally is going to put themselves in that space, and they're able to ground themselves in that space. If your client can't do that, then that's what you need to work on first. And that is what's called the work before the work. Then what we do is the client says that the visual, this particular visual, I just took something that we've all seen, is a visual from 9/11. It's just the client is saying for some reason they're having disturbing flashbacks of the specific scene that they saw on TV. And so the little picture is going to be the picture in picture. And the client gets to take that picture and, oh, shoot, I can't move it. I don't know why I thought I could. And the client can put the picture anywhere they want. They can put it behind the trees, back as far back as they want. They can make it as small as they want, and they can make it with the remote control. They have complete control of when they want the picture to disappear if they need to, which is identical to a stop or a timeout. And so you have the client ground themselves in that hike. And then you have them switch over, and a lot of clients do this with their eyes shut, switch over to that very small, disturbing picture, a snapshot of the flashback. And you want to stay there for just 3 seconds, and then move the client back to their large screen. Breath in, exhale out. Maybe you use some of the language depending on what works for your client. Now you're back in your forest and you're feeling the breeze and you're hearing the birds. And what was that experience like for you? Is it okay if we try that again? We always want to have permission. And the goal is to then to go back to the picture and do it for maybe 5 seconds. One thing that's helpful is if you, the therapist, count while the client is experiencing the traumatic incident, because counting is distracting. And we have research now that says if you distract the client while being disturbed, it actually helps with bringing down the dysregulation. So the client's in their hike, they're going to now move. I am an EMDR therapist, so I will tell you that the eyes do move across to the little picture, which is helpful as well. But so the client is now in that small picture. The things that you can start to do is they go for 3 seconds, they go for 5 seconds, then you can have them make it a little bigger. And the goal is that you're titrating, you fractionated, you are titrating, and you are pendulating. And then you are also educating the client around, we are in present time today with our hike, and now I'm taking you back into trauma time momentarily, and then I'm bringing you back into present time. And what was that experience like for you? Okay, so that is an example of picture in picture. Yesterday, I want to make sure I get to everything. Yesterday, I had one of my trainees, so I do a lot of consultation, and I had her do it with me. And I don't know if any of you saw the picture of the Chinese airline that went down, but it is a very disturbing picture for someone like myself who was terrified to fly. But I am no longer terrified because I did EMDR. But the picture was very disturbing. And so I also have a hike as my calm the calm imagery that I use. Now, I do a lot of EMDR. I have 2 therapists. I do it twice a week. I have very, very strong, well-developed, strengthened, and enhanced positive neural networks. And so for this to happen for me makes sense. Do not expect this with your clients right away. But when my trainee was doing the picture-in-picture with me, I started in my hike. I went to the disturbing picture. I came back. Then I went to my disturbing picture a little longer and I came back. And then she took me to the disturbing picture. I enlarged it with my remote control and I came back. And I'm just going to tell you the experience I had was the picture is the plane nosediving, which I've never seen before. The visual for me started to shift, which is what we want eventually. And the first or second or third time that we did it, I had a visual of God's hands around the plane. And then it almost wants to bring tears to my eyes. The final visual was literally when the plane impacted the ground. God was like this and all the souls were going to be with God. Oh. Anyway, okay, so that's picture-in-picture. I like to use examples when I teach. We're going to move to another one, which is constant installation of present orientation and safety. And this is very similar to picture-in-picture, except instead of using visual imagery, because there are going to be clients that can't do this, we're going to use secure the space. And the space that you're securing is going to be either the space that they're in right now, or it's going to be what I'm finding virtually their space. So for example, I work with a lot of adolescents. They want to do online therapy. They are better in their room where they've created secure spaces for themselves than they are in my office. That's what I have found. And so we're going to do the same type of thing here. We're going to have the client secure their space, and then we're going to work on pendulating them back and forth, utilizing that same language. Since we're not doing picture-in-picture, we don't have a remote control. We're not utilizing any of those tools. But literally, the title of this is Constant Installation of Present Orientation and Safety. And it is teaching the client to be present, to enter into trauma, and then to be present, which is what trauma work is to begin with. So here's the example. My client, adorable, securing his space. He has, so the therapist, what about your space makes you feel secure in this moment? The client says, my bearded dragon, Lucy, and my turtle soup. I love the name of the turtle. And the therapist says, describe it for me in detail. And the client says, I can hear my turtle tank in the background humming. Soup is swimming around. I can take Lucy out of her cage, which I have them do actually quite often. And she just sits on his chest and he pets. And that's very grounding for him. And then, I'm sorry, the bar is probably going to be in the way here. You want to give it a measurable, because when we secure our space, we want the client to be able to tell you session after session, the measurable. And so how secure do you feel from 1 to 7, with 7 being secure? And the client says, right now, I'm a 7. And so when I meet with the client the next week and the week after and the week after, I'm going to say, how secure are you feeling right now? And they're at 1 to 7. And I'm going to say, you know, just check in with your turtle soup and your lizard, Lucy, and your boa constrictor, Mellow, all kinds of fun things that our clients have in the background, and that will help secure their space. And then what we're going to do is we are going to pendulate, all right, or toggle back and forth. So this particular client had a friend that overdosed and went to see her in the hospital, and the snapshot of the worst moment was her in the hospital bed. hence the picture. And so the key to this is that you have the secure space and that you are only doing a snapshot of the worst moment. That is the fractionating and the titrating. If you were to do something bigger, like her memories of her like engaging in the overdose in some way, shape, or form, that is not going to work because it's going to be too much for the client. Bam, they're out of their window of tolerance. So you want to keep them in their window of tolerance by literally toggling them back and forth from their secure space to 1 to 3 seconds in their visual, the snapshot of the worst moment, and then bringing them back to their secure space. I want you to hear that turtle tank. I want you to just go ahead and pet Lucy. I want you to feel Lucy on your chest. How are you doing? What was that like? That was okay. Okay, we're going to try it again. This time we're going to do it for 3 seconds. Then we do it for 5 seconds. Then we do it for 10 seconds. Once again, counting is something that you can incorporate. I would recommend it so you could see how it works. When the client goes, let's say for 10 seconds to that worst moment, you just have the client move into that visual, and then you can do it together or just the client alone, or you can count 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Breath in, exhale out. Moving back into our secure space, listening to the turtle tank, feeling the lizard. Another breath in, exhale out. We can do a grounding. One of my favorite groundings is the 3-3-3. Have the client look around and point to 3 things that are rectangles. I've got a picture, I've got a book, I've got the table over there. I want you to look around the room, find 3 things that are red. Once again, I've got some books, I've got a candle, and I've got a ceramic. And then let's shake out 3 parts of our body, rolling our shoulders, stretching out our neck, breath in, and exhale out. I'm now listening to that turtle tank and being with Lucy. What was that experience like? What's coming up for you now? Okay, so that's constant installation of positive orientation and safety. And then once again, the education is going to be that moving from present time to trauma time to present time is literally what it is that we want our clients to be able to do when they are not in session. And I'll talk a little bit about that at the very end. So our last but not least is Jim Knight's Loving Eyes. Jim Knight's Loving Eyes is going to be parts work. So we want to help an adult part overcome some type of phobia or avoidance to a child part by forming a visual image of that child. So this is a little different than what we were doing before. And how does this work? This is going to be like you're doing some work with the client, and the client's just like, oh, I'm feeling so much sadness. I just had this yesterday, actually. I'm feeling so much sadness. And then I'm like, oh, Jim Knight's Loving Eyes. And I'll say, you know, how old is that sadness? And client will say 5, 6 years old. And I'll say, are you able to see that child? Are you able to notice that child? We want the clients to engage in curiosity and in caring and in understanding. And so let me go through the example. So the client says, I feel so sad. And the therapist says, how old is that sad part of self? And you can use the word aspect if you don't like the word sad. And then they say 6 years old. And then the therapist says, can you see that 6-year-old? And if so, what does that 6-year-old part or aspect of self need? And nobody's going to know better what that aspect needs other than the client. To be loved unconditionally and kept safe. So then the therapist says, I want your adult nurturing part of self. So remember when we did the parts inner family, there was a nurturing part. Well, that nurturing part is going to be a part that you've worked on already with the client. I want that adult and that nurturing part of self. And so in that particular inner family, the adult and the nurturing part were pretty well developed. I want them to go, and once again, I'm really sorry about this bar. I want them to go and to the child part and give them what they need. So once again, we've got the adult nurturing part that's in present time orientation, going to the child part that's in trauma time, and giving that child what it needs. And so what would that look like? That would look like the client envisioning, nurturing adult part, going to that 5-year-old child, maybe hugging that child, telling that child, I'm here for you. You know, it wasn't your fault when your dad was drunk. I love you, and I'm sorry you had to experience all those things, something to that extent, where you are being able to, as the therapist, see that the client can access present orientation, go into trauma time, and then come back out. And whatever the client shares with you is going to be information for you. It's going to be data for you. And so, you know, things that can go wrong, and they do, especially with highly traumatized clients, is going to be that that child part is not deserving of love, is not deserving of safety, and that the adult part isn't capable. I have a client that came from an orphanage, and she had absolutely no idea how to nurture something. She thought you just laid on top of it. So this is all data for you. This is for you, like I said, once again, to understand your client's clinical landscape and be able to know that if the client has an adult part that doesn't know how to nurture, that will be the work before the work. Or if you have a child part that feels so undeserving of love, that's going to be some of the work that you're going to do. And you know what you do, it's called unblending, and it's not hard to do. You just need somebody to tell you what it is. So just to kind of review here, I'm wondering, I'm not leaving a lot of time for questions, that we talked about fractionation, titration, pendulation, education. The key is present day orientation and visiting trauma time. You and the client visiting the trauma, not the client going by themselves and reliving it, and utilizing you know, window of tolerance and polyvagal perspective to introduce and to help the client prepare for state shifts, understanding parts of self, understanding how the autonomic nervous system works, giving it language, and then going in and utilizing something like picture-in-picture. CPOS is what we call constant installation of present orientation and safety, or doing a parts exercise, something like loving eyes. So this is for me to read and not for you to read. So I'm just going to, this is my conclusion. So let's put this all together. Our clients come in and we want to know their trauma history and how it plays out in their current life. Our number one question to ourselves is, what is this level of dissociation? And how does this influence our treatment plan? Even if the client wants to focus on their anger with their children, we want to understand that past-present connection. We want to understand that 20-80 rule. 20% is about today, 80% comes from the past. We want to know what it is that our present orientation is going to visit, and how the central nervous system works, and in what capacity does dissociation assist the client when functioning. We use our DES as the screening tool, which may then lead to the MID if the client is highly dissociative. You do not need to know anything more than what we've talked about today around using the DES, and the DES, being that it's the color-coded, will assist you in learning around dissociation firsthand from your client. And then we will integrate the window of tolerance psychoeducation. And that's actually the window of tolerance and polyvagal together. As well as viewing them from a polyvagal perspective to assist with language and an understanding of state shifts, we will then use our tools. We will fractionate, we will titrate, we will pendulate, we will educate to assist with keeping our clients present and in dual attention throughout our work. As long as the client is in their zone of arousal and we can receive, process, and integrate a disturbing memory, you are allowing the maladaptively stored memories to be appropriately stored through a natural healing process. So when I said to you, when I first started as a trauma therapist, that I was like, okay, we're just going to talk about those trauma memories. And that's what I thought trauma work was. I didn't take into consideration in any of this. And my clients were overwhelmed, out of their window of tolerance. And I really had no idea what to do or what I was doing. So I hope that this presentation has been helpful in that it gives you not only a way to start using a screening tool, but then you can learn from it along the way. And I hope that you join us in April for the polyvagal presentation, because I believe that looking at our clients from a polyvagal perspective is imperative. And so, yeah. And I'm sorry there isn't a lot of time for questions, but I think I did a good job of getting the presentation in. So anyway, do you have a couple questions you want to pull out?
We do. Okay, so I will kind of work backwards because there are several on polyvagal. The first is Deb Dana's theory and therapy book enough to fully understand polyvagal theory, or should we also get the Porges book? Is watching the Porges video and Dana book sufficient?
Can we do this with polyvagal? I'll answer that question, but I am going to do polyvagal next time. But yes, Deb Dana's book is all you need. Stephen Porges is lovely. He's just really hard to understand. So, I mean, if you're a scientist or if you have the background where you can understand what he's talking about, then by all means, go to him first. But Deb Dana does a fantastic job.
Okay, great. And then are the videos on your website as well, Paula?
Yes.
Okay, yep. So the videos and the handouts are on your, so everyone will receive a PowerPoint presentation in their email, and then also Paula's website has the videos and the handouts.
Yeah, I need to put the part one on I think I'm going to put that on my website.
Okay. Okay, going back to some of the ADHD questions, would we consider the time blindness that we see in ADHD as derealisation?
I can't answer that unless I know the trauma background of the child. Because like I said, it's very similar. And at the end of the day, if the client is not able, or if the child is not able to focus, if it's ADHD or if it's trauma, clearly that's going to make a difference. But without the appropriate information, the appropriate data, I can't make that determination.
Okay. Let's see, that's like another ADHD. Okay, what do you tell a client who's questioning the veracity of a newly surfacing memory? I have a client who just remembered being sexually abused by her father, and she's terrified. She asked if memories like this can just be a product of one's mind.
Very typical for clients that are coming up with new memories to think that they're not real. There's usually a part of them that protects them by telling them that they're not real. That is all going to be seen. You're going to be able to work with that doing parts work. You need to do the DS with her, because if you have clients that are coming in with childhood sexual abuse, they're usually pretty dissociative. So start with the DS one day at a time, and then get some good consultation.
Great. Okay. And what do you do to help a client reconnect to their body? Grounding techniques, progressive relaxation, etc.
Yep, all of that. Absolutely.
Okay. Is there a diagnostic tool you recommend that diagnoses both PTSD, including dissociation subtype? I use the UCLA, which does have a part of it that asks about dissociation. However, it's only based on 4 questions. I often find they may not score high enough for the subtype based on these 4 questions. However, they have many other symptoms related to dissociation, and was hoping for other tools to diagnose both. I treat mostly complex trauma with teens and families, so feel this is such an important piece.
Yes. Reach out to me at emdrchicago@gmail. Right over there in my bookcase, I have a number of tools that they use around the world. So, but I just, if I go over there and get it and look for it, it's going to take some time. So I'll send them to you.
Great. Okay. And then what would be a good book by Paulson to read more?
Oh, well, the one that I put up there, which was Trauma and Dissociation, but there's another book that she does. I think it's called There Are No Words. And it's going to be about pre-verbal trauma and how to work with it. Lovely books, fun to read, fun to color.
Awesome. Okay. And then I think we're just going back to the amnesia versus memory loss due to aging. If you have any other thoughts on that.
Yeah, I don't.
Okay. Okay.
Yeah.
Oh, do you have anyone you would recommend to reach out to ask for consultation for dissociative clients' cases?
It depends on the background. If you've got, of course, my world, I've got a lot of referrals that are going to be for those that are EMDR trained. So once again, reach out to my email, tell me what their background is, and we'll see if we can find a good match for them.
Okay. Where do we place the absorption and the emotional detachment that it can occur with taking Adderall?
So when you say absorption, are you talking about the numbing of the feelings?
I don't know.
Okay.
I'm assuming.
Well,
And the emotional detachment.
The absorption with Adderall. So that's going to be another ADHD question. Okay. You know what? I'm going to stay away from that one too, because I don't work with medication, and yeah, I don't feel qualified to answer that.
Okay. And she is saying yes. Okay. And then I think the other one, how about in regards to adolescents, when using the adolescent DES, it isn't color coded.
It isn't. And the questions still line up with the color coded, but you'll see that the adolescent DS, the language is very different. And I highly recommend using it with using that one instead.
Okay.
So you can match up the questions. It's still 28 questions.
Wonderful. And then I believe that is it. It looks like you're getting a ton of amazing feedback. So thank you so much.
Yay!
Again, April 20th, 10 a.m. to noon will be the polyvagal polyvagal theory presentation that Paula will be doing as well.
Yay, you guys, thank you so much. I know that we're all really busy. You know, I feel very passionate about this topic. So thank you for being here.
Wonderful. Thank you, Paula.